Hello students and e-learners. I am Surya, working as Assistant Professor in School of Allied Health Sciences, Vinayaka Mission Research Foundation, deemed to be University, Salem. Today we are going to learn about psychophysical perimetry. Before going to the session, we know what is perimetry and we saw brief introduction of glaucoma. As we know, glaucoma is one of the leading cause of blindness worldwide, yet in earlier stages it is essentially a symptomatic disease. We know that glaucoma, what is a glaucoma? It is not a single entity. It is a group of diseases characterized by optic nerve disorder problems, which is clinical features such as changes in CCT, changes in intraocular pressure, changes in angle of anterior chamber, there will be an increased angle of cup disc ratio, and also the visual field effects. Patients may present with normal IOP, and definitive diagnosis via ophthalmoscopy or fundus microscopy can be challenging. We know that in the primary case of any type of glaucoma, whether angle closure or open angle glaucoma, in the primary stage it is symptomatic. No, it is asymptomatic. What is perimetry? Before getting into the session, we know what is perimetry. We all know what is kinds of perimetry. There is a static kinetic perimetry which is available, which is used to learn about visual field patterns of a glaucomatic patients. Usually in our day-to-day practice, we use the white on white SAP, which is an static automated perimetry, remains the current standard. It may fail to detect early glaucomatous damage because there is lots and lots of study which spoke about visual field perimetry, which is an SAP, static automated perimetry, and are also the correlation with the structural changes of optic nerve head problems. There is a lot of correlation in that, which mean that there will be a possible chances of static perimetry find out the least starting stage, which is an early stage. It is difficult to find. A major portion of modern eye research is therefore devoted to finding better diagnostic approaches, broadly classified as structural and also functional. Structural we may easily found out by OCT such as RNFL, and functional there is a psychophysical parameter which is available, which is we learned today a topic. The current diagnostic tools for glaucoma find out and also their limitations. There are several lots and lots of instruments because glaucoma is a leading cause of blindness, preventable blindness. According to World Vision report, glaucoma plays a top 5th criteria for preventing blindness. There is lots and lots of patients each and every day in our clinical day practices. We saw lots of patients. The current diagnostic tool which we use are HRT, which is a Heidelberg retinal tomography, which based on the principle of confocal scanning ophthalmoscopy. It is quite expensive, limits accessibility in many clinical changes. And also GDX, which is a glaucoma diagnosis, which is based on scanning laser polarimeter. It is also the cost restriction is there, and also particularly in resource constrained environment it is very limited. And on the other hand, OCT, optical coherence tomography, which is based on Michelson interferometer principle, while highly informative, the structure remains, it is also cost effective. We may saw that OCT in lots and lots of clinics in our day-to-day practice, but while comparing with the patients who are affecting glaucoma and also the availability of OCT, it is still debatable concept, because if OCT instrument is available in each and vision screening centers, that only we found a lot of preventing the blindness caused by due to glaucoma. And hence also the OCT has a limitation because some of the OCT available in the market is not portable also. And the next one is RTA, which is retinal thickness analyzer. It is also expensive and we need a specialized technician. There will be a greater learning curve to handle this RTA. And the next one is SWAP, which is short wavelength automated perimetry, which is also a psychophysical perimetry. It is long and difficult test for patient leading to poor compliance and unreliable results. It is quite effective for checking the parvocellular pathway. Parvocellular pathway, it is quite okay, but in finding the earlier stages, such as finding the magnocellular pathway, it gives an unreliable results because the test background is yellow and the test target is blue. This will conflict the results. What an ideal early detection test should look like. For finding the earlier glaucomatous stages, what will be the instrument should show? It is sensitive to find the subtle changes. The test may detect the earliest glaucomatous changes before significant structural changes may happen. Because if the structural changes happen for a glaucomatic patient, the vision loss due to the glaucoma is irreversible. So we need to find as much as possible. Catching the disease early when intervention is more effective. The next one is affordable. cost must not be a prohibitive cost. Widespread screening and early diagnosis require instrument accessible to general ophthalmology and optometry practices. Cost must be very, very low for a screening purposes. In our day-to-day practice, we did confrontation as a screening tool, but some of the instruments, which is psychophysical instruments, are available as a screening tool, which we see in the classes. The next test is easy, convenient and fast. The test should be straightforward to administer, comfortable for the patient, because instruments such as SAP, static automated perimetry, the test duration is quite long. It should be comfortable for the patient and quick to complete, reducing fatigue related variability and improving clinical outflow efficacy. Before getting into the session, we need to find out what is the principle of psychophysical perimeter. Before getting into that, we know what is a physical visual perception, because visual perception is nothing but what we see, what we think. Let me see into that example. This one is a iliac circle. Let me do an experiment by this video. In this image, we saw a cross which is surrounded by pink shades, which is nothing but a pink tinges which is around the cross. Before blinking, look at the cross for 10 seconds. Before blinking, we should not blink and we should focus on the cross for 10 seconds. Let's see what will happen. 1, 2, 3, 4, 5, 6. Yeah, the dots disappeared, right? For me, the dots disappeared in 6 seconds. For me, the dots disappeared maybe varied. The reason for this disappearance of the pink dots which surround the cross is that there is a specific on and off pathway in our visual system, which is magnocellular and parvocellular, and also the ganglionic cell pathway, lateral geniculate body, which lots and stuffs are coming into that. Let me oversee what it is. When we concentrate at the plus, the fovea system send a constant signal to the brain's visual cortex, and the peripheral retina, which having a less, in layman term we may sort that while focusing at a center dot, the peripheral area which seems blurry or which seems tired, so it automatically suppresses the results of the periphery. This is one kind of perception. Let me see what is the visual perception, which is based on psychophysical experiment. This is a table fan. We know what it is. How many blades did you notice in this table fan? Some may have say 4 blades are there, some may say 8 blades, some may have say 5 blades, but actually how many blades are available in the table fan is 3. Why it appears is so much. The reason is that frequency doubling illusion is the principle based on this. If you look at the fan, there is a numerous number of blades will appear. The reason is that frequency doubling illusion. This is the main key principle of frequency doubling perimeter that we are going to take in our classes. Look at that chart. When we see a grid of black lines, black lines and white lines. The grid is nothing but a sinusoidal wave. Sinusoidal waves is nothing but a waves where the crest appears as black, whereas the turf appears as a white. This is 1, 2, 3, 4, 5. 5 square grids of sinusoidal waves are present in the upper image. In down, the black appears as white, the white appears as a black, which is nothing but the wave will start as this. While flipping these two waves front and back, or when we move the waves to flow, the image will appear as a 10 squares. We are giving stimulus for only 5 grids, but the image will appear as a 10 square grid. The reason for this pattern is similar to that of table fan. In table fan there is only 3 blades. When it runs, it will appear as a multiple blade. Similarly, in a very minute category of low frequency waves, these 5 waves, when we are moving, it appears as a 10 waves. This was the principle which based on this a frequency doubling perimeter. We will see how it appears. The magnocellular pathway, as we discussed about, the on and off cellular pathway plays a greater role in visual field effect. The magnocellular pathway, it is a key role for detect a yearly glaucomatous detection. It is a new psychophysical test developed with a more targeted neurophysical rationale. Magnocellular ganglion cell, the larger retinal neurons responsible for motion detection and low contrast sensitivity. There is an M cells, another one is a P cells, another one is a K cells, which is magnocellular, parvocellular and coniocellular pathway. pathway, each cell have a specific function. In this, the magnocellular pathway is responsible for motion detection and also for low contrast detection findings. In glaucoma, the first defect will appear with the low contrast problems, changes occurrence in the glaucoma. Hence, the first cell pathway which affect due to glaucoma is magnocellular pathway. If we find that pathway defect, we may find out the early stages of glaucoma. This is the first neuron which is damaged in glaucomatous condition. A test that selectively isolates magnocellular function should therefore be highly sensitive to early glaucomatous changes which potentially defecting damage before it appearance on the white on white perimetry, which is a static automated perimetry example, Humphrey field perimetry and so on. Octopus, there is lots are available. The Humphrey frequency doubling perimeter was developed specifically to exploit this vulnerability of magnocellular pathway defects. There is two generations in frequency doubling perimetry. The first generation is the original FDT, which is the foundation frequency doubling perimeter, established the clinical validity of magnocellular targeting testing through years of research and clinical trials. As we discovered what is the illusion pattern behind this. And the second generation is FDT matrix. FDT matrix is frequency doubling technology matrix. This has more test points across the visual field using smaller criteria. Smaller test area will be subtle changes will be found in very small places also will be found by the second generation perimetry. It familiar our data output, because while comparing with the first generation, the second generation FDT which will pattern which is similar to that of HFA, Humphrey field analyzer. Both the results are same, so it is not difficult for being an optometrist, being an ophthalmologist. The test output is similar, so it is the learning curve does not become a hurdle for this. FDT designed for real world clinical practice. Yes, FDT engineered with practical deployment in mind. Compact form factor allow it to function not only as a diagnostic instrument but also as a pre-test screening tool. Yes, there will be an option of screening tool also. Instead of confrontation, if we use this FDT frequency doubling technology perimeter, the quantitative, not only quantitative, the qualitative reports also will be found ASAP. Combination of affordability, validated performance and years of use position the FDT as a clinical practical solution for early glaucomatous detection. The main advantages as compared with the other white and white perimetry is it is portable because it is a small size. It is easily carrying out for while using a cam, or when you are going for occupation optometry camp, whatever, it is user friendly and specifically engineered to activate the magnocellular pathway. It is specifically check the M cells only, so the early detection of glaucoma it is very possible. The full threshold, while comparing with the white and white perimetry for find outing the full visual area, in FDT, the full threshold time is just 4 minutes for an eye, and hence the visual field of both eye will check within 8 minutes time. 3 diopter tolerance, refractive tolerance, the test patient up to 3 diopter uncorrected refractive error. In white and white perimetry, there is possible chances of that lens refractive error, there will be a chances. So for the screening purpose, there will be a chances. In this FDT up to 3 diopter, there will be no necessity to put in the trial lenses for the perimeter. There will be no requisites for this FDT. And the screening test is just 45 seconds. It is as much as low time from the confrontation. Yeah, complete screening test will generate within 40 seconds for an eye, and for both eye it will check within 90 seconds, which is 1.5 minutes. The signs of frequency doubling. The FDT stimulus exploits a unique property of M cell pathway, understanding the mechanical explains. The first one is a flicker frequency, which uses 15 Hz as a flicker frequency. The second uses, which is a mechanism based on the FDT, is non-linear magnocellular response. So the non-linear is nothing but we giving only the 5 square waves in the test target, but when the waves are moving it will appear as 10. This form of converting 5 to multiple images is called named as non-linear responses. This was utilized in FDT. Large grading for poor spatial resolution. There is a grid pattern is large. The magnocellular system has a poor spatial resolution and the P cells have a greater spatial resolution. This poor spatial resolution will utilize in this principle of FDT. Contrast sensitivity as a measure of neutral integrity. In white and white perimetry, we will be using decibels, where the light stimulus we may alter Starcase method. But in this FDT, we are going to use contrast sensitivity. How the test use? Contrast of the flickering grating is varied until the patient can no longer detect it. We may also saw a Pelli-Robson chart where the contrast decreases when the line approaches, the triplets approaches at the bottom of the level. Similar contrast level was utilized in this FDT. What elevated threshold mean? If a significant number of magnocellular fibers are damaged by glaucoma, the patient will require high contrast to perceive the grating. If they find at the low contrast, the patient is fine. If the patient will detect only at the high contrast, the patient will have the changes due to the glaucomatic conditions. This is the fundamental of contrast sensitivity chart as we discussed. Pelli-Robson chart tried to isolate the magnocellular function. Advantages of FDP, as we discussed, it is a fast and efficient time, only 45 seconds required for the screening tool, and superior sensitivity. It is portable and compact. Refractive tolerance up to 3 diopters. This was the key difference between the first generation and second generation frequency doubling perimetry. The first generation perimetry have the test strategies such as C20. Similar to that of white on white perimetry, this FDT uses two test strategies such as C20 and N30. In white and white perimetry, we may use 24-2, 30-2, 10-2. Similar to this, in this FDP, we are using C20 and N30. C20 is nothing but center 20-degree examination test strategy, and N30 is nothing but a nasal 30-degree. In C20-degree pattern, there is a one stimulus at the center, which is surrounded by 4 peripheral stimulus targets. In N30, there will be 2 add-on patterns at the nasal side, which is an superior and inferior of the horizontal meridian pattern. The target size which is used in the first generation is 10 degree at the peripheral, whereas the center it uses 5 degree. The wave which is used in the first generation is 0.25 cycles per degree, and the flicker rate was 25 Hz. The time duration was 720 milliseconds, which is nothing but the first 160 millisecond, the contrast level is gradually increased. After that, the 500 millisecond, the contrast level is maintained. After that, the 160 second, the contrast level is decreased. The response time is 0.1 second to 1 second, which is 100 millisecond to 1 second. Within that time, the patient need to respond. If they didn't respond, the pattern will recognize that the patient is unable to see. Similar to that of staircase procedure in white and white perimetry, it uses MOBS technology. The common test strategy is N30-1 and N30-5. The test duration for first generation FDT is 30 seconds for a normal person and 4 minutes for a patient having visual field defect. In FDT matrix, which is a second generation perimetry, it have 3 strategies such as 24-2, 30-2 and 10-2. In 24-2 and 30-2, the target size is 5 degree, which is very small as compared with the first generation, and it is so that only it will find a smaller problem ASAP. It uses wave of 0.5 cycles per degree. The frequency also it is very less, it is 18 Hz. While comparing with those two, the 10-2 which will affect only on the macular region, the target size is very much reduced. The target size is 2 degree and the test target which is frequency is 12 Hz, and the time duration is similarly 720 milliseconds, which is nothing but for the first 120 seconds the contrast level is keep on increasing for the 120 millisecond. After that, the contrast level is maintaining for 500 millisecond. After that, the contrast level is decreased for 160 milliseconds. If the patient didn't see the target at the 500 millisecond, the contrast level is lower, similar to that of staircase. If the patient is found at the 500 millisecond, the contrast level will increase for the next target. This was the clinical setup of FDT, similar to that of white and white perimetry. We need to place our chin here, and we need to give a remote when the patients see the target. They are asked to press the button. This is the opening of the screen. This is the patient view. We need to say the patient to fix at the center. Similar for the right eye, after for the left eye. In the patient view, the target will be appear like this. This have a contrast level of approximately something, say example it is 10 log units. If the patient is responded, the next will be appears as 5. If the patient didn't respond, the contrast level will increase. As staircase method, this pattern also will rise. The next psychophysical perimetry is pulsar perimetry. Similar to that of FDT, it uses a single wave, but it is a one-dimensional FDT, which is using only a single wave as single grid. But in pulsar perimetry, it uses two-dimensional wave, which is nothing but wave from different this appears black, this appears black, this appears black, this pattern appears black. In the whole thing, it will appear as a circle. Similarly, circle pattern will appear for the pulsar perimetry. Keep pointing note that FDT, which is a frequency doubling technology, is a single dimensional wavefront will be used, whereas in pulsar perimetry, two-dimensional frequency gratings will be using. And the next psychophysical perimetry type is FDF, which is flicker defined form perimetry, which is available in Heidelberg edge perimeter. In this perimeter, they didn't use a wave grating. In this, they are using multiple dots. The white dot will appear as black and the black dot will appear as white. While shifting this black and white dot, there is an edge illusion of circular pattern will be found for a patient. If the patient is finding those circular pattern, they will press on the button. If they didn't know that, they won't press the button. Similar to that of contrast level, there will be changes in a staircase method for the patient. It is also very well useful. And the next psychophysical perimetry is short wavelength automated perimetry, which is available with HFA, Humphrey Field Analyzer. It uses a yellow background and blue violet target will be used. If using a yellow target and blue violet target on a yellow background, there will be a chances of stimulating parvocellular pathway, because parvocellular pathway will be the reason for finding the colors and also high frequency findings and also shape. These factors will stimulate the parvocellular pathway. We are giving a stimulus of yellow background, and hence the parvocellular pathway will be a confounding factor if we are accessing the magnocellular pathway. So SWAP is not a clinical tool for measuring a magnocellular pathway, and also it is not valid for the ELA changes. These are the various psychometric perimetry available in the market. The first one is FDT, frequency doubling technology. There will be two generations is there. The most advanced one is a matrix, and then pulsar perimetry, which uses two-dimensional wave grading for finding the patients. And after that, we saw flicker defined form perimetry. In this flicker defined, they didn't use any waves. They are using a multiple dots, and the dots will be changing black and white, so that a pattern of edge illusion will be formed. And the next one is SWAP. It is purely for parvocellular function, not for magnocellular function. These are the different perimeter which utilizes visual illusion as a factor. Visual perception, it will be happening at the brain level, at the visual cortex, primary visual cortex. We may have question about visual cortex, how the visual perception will happen. Still, you are not believing that the visual perception. Let me end up with this example for your findings. In this picture, what are the things you may see? You may see a checkerboard pattern and a green cylinder which is placed vertically. After that, alphabet A and B, right? If I'm asking A is darker or B is darker, you may say A is darker. Take time and notice which one is darker, A or B. Most of them say A. The reason for A is it appears as more grayish as compared with B, but the actual truth behind is this: both are at the same level, both are at same pattern, both are at the same grayish level. If you still not believe this, close your hand with a cylinder and look up the A and B pattern. It will appear as the same. Let me see the construction of this. Both A and B are same, but after the fulfill of the texture, you may see that both are not equal. The reason for this psychological visual perception is that in this cylinder, the checkerboard pattern type, which is an Algen circular checkerboard square, this is the name of the image. In this image, you may see that the shadow of the cylinder. In our brain, we used to practice that if shadow is there in a particular place, that object will appear as a darker. So even though B appears as a darker, the shadow is there, so that only the image will appear as a darker. This was the conception which was stored in our brain, and hence the visual perception entirely differ from what we think. Instead of treating myopia, hyperopia, astigmatism at the retinal level, we should concentrate for the visual cortex level in the future. Thank you, students. Thank you for listening.